Good afternoon, everyone. Again, thank you for coming. We are still waiting a little for a couple more minutes for the folks to sign in. So please bear with us for a couple more minutes.
Bienvenidos a todos por llegar. Estamos esperando que otros entren y que anuncien su presencia un par de minutos más.
Okay, let's get started. Good afternoon, everyone. Thank you for joining us today. I'm Hye-yeon Park, manager of the Health and Ecosystem Analysis section in the research division at CARB. This is a public workshop on evaluating new health endpoints for use in CARB's health analysis. Before we start, I'd like to provide some instructions. Next slide. The Spanish interpretation is being provided for today's workshop. Note that the interpretation feature does require downloading the Zoom application to your desktop. When you have the Zoom application open, you should see an interpretation icon that looks like a globe located at the bottom. You can click on that and you should be able to select whether you want the English audio or the Spanish audio. If you select the Spanish audio, you should also select mute original audio. Otherwise, you will still be able to hear the English audio in the background. And next slide. Today's meeting is being recorded, and we will respond to your questions at the end of the workshop. Throughout today's workshop, you may type your questions at any time into the Q&A using the Q&A icon at the bottom. At the end of the presentation, if you wish to provide a verbal comments or question, you may raise your hands to be added to the speaking queue. And next slide. With the housekeeping done, I'd like to turn it over to Elizabeth Shirley, the Chief of the Research Division at CARB, and she'll provide some opening remarks for the presentation and workshop. Elizabeth?
Thanks, Hye-yeon. As Hye-yeon said, I'm Elizabeth Shirley. I'm the Research Division Chief, and I just want to welcome you on. Thank you for taking the time to attend our public workshop today on evaluating new health endpoints for use in CARB's health analysis. CARB is dedicated to the mission of improving public health and welfare as we pursue air pollution reductions. And over the years, we have quantified the benefits of our rules, plans, and programs using the best information available to help the board and the public better understand how our work is contributing to improved health. As the scientific understanding of air pollution's health impacts has grown dramatically over the years, there's much more information on health impacts that we can calculate and include in our health analysis for consideration in the regulatory processes. The work we're presenting today was initiated after a board resolution in April of 2020 that directed staff to investigate broader ways, including both quantitative and qualitative ways, to present those broader health impacts of air pollution. And we're pleased to be able to share with you today some updated health research that serves as the foundation for our analysis and our proposal for additional health endpoints to reflect the latest science. I'm now going to ask Bonnie Holmes-Jen to provide some additional comments before we get started.
Thanks, Elizabeth, and good afternoon. I'm Bonnie Holmes-Jen, Branch Chief for the Health and Exposure Assessment Branch in CARB's Research Division under Elizabeth. And I also would like to welcome everyone to the workshop today. Our branch in the Research Division is responsible for the ongoing health analysis of regulations and programs for the agency, along with health research to better understand air pollution health effects and vulnerable populations, and many other important health projects. We have 3 sections in our branch that are focused on important aspects of our health work. Just to give you a quick introduction, our health and ecosystems analysis section is managed by Hae-Yoon Park, who you've met just a moment ago. We also have our climate and health analysis and library services section managed by Barbara Weller, and our buildings and indoor exposure section managed by Pat Wong, and they're all on the workshop today. We have been focused as a key priority on ways to expand our health analysis since the board resolution mentioned by Elizabeth, and we'll discuss this important charge in our upcoming presentation. Our staff has done a great deal of work to investigate health endpoints that can be integrated into our health analysis in preparation for this workshop. I'm very proud of the staff's work and looking forward to a great presentation and discussion today. So I'm going to turn it back to Hae-Yoon Park to continue with the introductions, and we'll get started soon with the staff presentation.
Thank you, Elizabeth and Bonnie. Now, I'd like to remind everyone that throughout today's workshop, you may enter your questions at any time into the Q&A in the bottom of our Zoom. And now I'd like to turn it over to the staff lead, Dr. May Betraratana, to begin the presentation. May, take it away. May, you are muted, I think.
Sorry, thank you. All right, so I have someone else in my house who's also on a Zoom call, so I'm just gonna be for a moment on the video, but I'm gonna unfortunately have to turn off my video just to preserve my audio. Okay, so thank you for the outline for today's workshop. We will first discuss what are health endpoints, and then we will discuss why we are updating and adding these health endpoints in CARB's health benefits methodology. And then we will discuss our approach for evaluating these health endpoints. And lastly, we will conclude with next steps in this process, and we'll have time for feedback and discussion with everyone. The first 2 bullets of the outline will be covered in this section on the importance of updating the health endpoints in CARB's health analysis. So first, what are health endpoints? A health endpoint is an adverse health outcome used for the purposes of evaluating quantitative or qualitative health impacts. And examples include mortality and morbidity effects, such as premature deaths or hospitalizations from air pollution exposure. Health endpoints can be used to evaluate the impacts from criteria air pollutants or air toxics, such as diesel particulate matter. For today's workshop, though, we are focusing on those related to PM 2.5. Now, how this relates to CARB's work is that health analysis informs the benefits of CARB regulations, plans, and programs. Our current approach quantifies a small subset of the full suite of benefits and is just for PM 2.5 only. We are currently quantifying cardiopulmonary mortality, hospitalizations for heart causes, hospitalizations for lung causes, and emergency room visits for asthma. For our ongoing work to update our health analysis, our goal is to provide a more complete evaluation of the health benefits of the agency's air quality and climate actions. Our effort to update the health endpoints stems from the fact that air pollution can cause health effects beyond what CARB is currently quantifying. This type of pyramid here has been widely used as an illustration of the varied health impacts of air pollution. It shows the relative number of people impacted, with more people impacted at the bottom of the pyramid from these health effects compared to the top. CARB currently quantifies mortality, ER visits, and hospital admissions, which are in the 2 segments at the top of this pyramid. As you go towards the bottom of the pyramid, more people are impacted by these other health endpoints, including lost work and school days, asthma attacks, and lung function decrements and inflammation. In addition, it is important to note that there are other health effects caused by air pollution which are not on this pyramid, including birth outcomes, as well as metabolic, neurological, and reproductive effects. Now, encompassing all the health effects shown on this pyramid, over the last several years, there continues to be a wealth of evidence showing the burden of air pollution on public health. In fact, the World Health Organization put together this 2016 report entitled Ambient Air Pollution, a Global Assessment of Exposure and Burden of Disease. In that report, there is this compelling quote that air pollution represents the biggest environmental risk to health. And this is supported by data compiled by the Institute for Health Metrics and Evaluation out of the University of Washington. This group is well known for their research on the global burden of disease. They recently published a study looking at the global burden of 87 risk factors. And as part of that study, they presented data showing that air pollution is in the top 5 out of the 87 risk factors for global deaths, and is actually at the top of the list when looking specifically at environmental and occupational risks for death in the world. In this graph here, air pollution includes both particulate matter and ozone. And together, they were estimated to cause over 85 deaths per 100,000 people in 2019. And in fact, the number of deaths caused by air pollution was over 3 times higher than the next environmental and occupational risk factor of non-optimal temperature, which refers to extreme heat and cold. Looking further at the data from the Global Burden of Disease group, most of the health impacts from air pollution are specifically due to particulate matter. In the year 2019, 4.1 million deaths globally were estimated to be attributed to exposure to particulate matter. A large majority of those deaths, about 60%, were due to cardiovascular disease, while close to 17% were due to chronic respiratory disease, and the rest were due to various other conditions, such as respiratory infections and cancer. Further evidence of the health impacts from air pollution exposure has also been summarized by the U.S. Environmental Protection Agency. The US EPA produces reports called the Integrated Science Assessments, also known as the ISAs, that discuss the latest air pollution and health research. These reports are part of the process that US EPA undergoes in establishing the National Ambient Air Quality Standards. Now, over the 10 years between their previous ISA for particulate matter in 2009 and their latest ISA in 2019, the amount of research has grown tremendously. In fact, out of 2,672 references that were cited in this 2019 version, about 70% of those references were new to this report. With all that, they therefore concluded that there is a large body of scientific evidence spanning many decades that clearly demonstrates there are health effects attributed to both short and long-term PM exposure. And those health effects are listed in the table on the right side, with long-term PM 2.5 exposure having a causal relationship between mortality and cardiovascular effects, a likely to be causal relationship with respiratory effects, nervous system effects, and cancer, and a suggestive of causal relationship with metabolic effects, male and female reproduction and fertility effects, and pregnancy and birth outcomes. Related to this table, it is also worth mentioning that the US EPA determines causality based on the strength of the studies and the volume of literature that have found associations with health outcomes. But this does not mean that those outcomes here that are listed as suggestive of causal, for instance, are any less associated with air pollution exposure than the others. This may instead reflect the lack of studies in these areas. And of course, this is a research gap that CARB and others are trying to fill. In fact, just this year, the US EPA also produced a supplement document to their ISA for particulate matter. This supplement further extends the evidence on confirmed causal relationships. And CARB worked with the Office of Environmental Health Hazard Assessment to provide a comment letter urging the US EPA to actually strengthen the causality determinations for some of these endpoints based on the latest scientific research. Furthermore, when discussing the health effects, the US EPA in their ISA and ISA supplement identified at-risk populations, both the general population as well as specific populations, including life stages, are at risk for PM 2.5 related health effects. Factors contributing to the increased risk of these health effects include where people are along the life stage, for instance, if they are children or older adults, whether they have pre-existing diseases or conditions like cardiovascular or respiratory diseases, and what their race, ethnicity, or socioeconomic status are. CARB staff understands that all of these and other factors are important in considering the health impacts from air pollution exposure. And while we don't currently have methods to incorporate localized data on at-risk populations, this is something we are continuing to investigate for incorporation in our health analysis approach in the future. Your comments and ideas on how we can best do this as we move forward are welcome. Besides the wealth of evidence showing the scope of the impact of air pollution on health outcomes and on various subpopulations, there is also evidence that even low PM 2.5 concentrations can cause health risks. For instance, that was demonstrated by this recent project report supported by the Health Effects Institute titled Mortality and Morbidity Effects of Long-Term Exposure to Low-Level PM 2.5, BC or black carbon, NO2, and O3 or ozone. Quoting from this report, this study contributes important evidence of associations between long-term exposures to relatively low concentrations of ambient air pollution and several important health endpoints. For PM 2.5, positive associations were found with these endpoints: mortality, stroke, asthma, COPD or chronic obstructive pulmonary disease, as well as lung cancer. Now, all of this evidence and others put together demonstrate that there are various health outcomes that CARB could quantify to provide a more comprehensive health analysis approach. In fact, the US EPA published a technical support document for one of their rules this year in 2021, describing several health endpoints that could be quantified. In looking at their list, there are 12 additional endpoints in this document that are beyond what CARB is currently quantifying. At the moment, CARB is calculating the 4 endpoints in purple, although note that for mortality, CARB is currently calculating cardiopulmonary mortality as opposed to all-cause mortality. And for emergency department visits, CARB is currently calculating for asthma as opposed to all respiratory. For our current work to update our health analysis, CARB plans to add the 8 endpoints in blue in the near term. These other endpoints that are in black may be considered in the future. We are focusing our near-term efforts on the endpoints in blue, since this set allows us to more quickly broaden our health endpoints across the different categories by considering 2 to 3 new endpoints each from respiratory and cardiovascular effects, as well as a cancer endpoint, and 2 new nervous system effects. US EPA recently used most of these newly updated endpoints in their regulatory impact analysis for the final revised cross-state air pollution rule in 2021. So CARB is looking to also integrate these new and updated health endpoints in our analyses, which is what we are presenting to you at this workshop. Today's workshop is part of our ongoing work to update our health analysis method, stemming from this board resolution in April of 2020, in which the board directed staff to pursue several actions towards this goal of providing a more comprehensive evaluation of the health benefits of California's air quality and climate actions. There are several points listed here. They are not in any particular order, but are meant as a framework of actions for CARB staff to consider and follow as we are updating our health analysis approaches. CARB staff are currently working on all of these actions, but today's workshop actually relates to bullet number 5, which is to investigate approaches to expanding the health analysis to include a range of additional health outcomes linked to pollution exposure. The other numbers on this list continue to be pursued by CARB staff and will be discussed at other times in the future. All right, now this leads me to the next section of this presentation. But before I get into that, let me take a brief pause here to remind everyone, especially if you joined us late, that throughout this presentation, you may enter any questions into the Q&A and we will address them at the end. We will also take verbal comments and questions at the end as well. Okay, so with that, now I will go into the second half of our presentation, which is to describe our approach for evaluating the health endpoints. But first, before we get into the endpoints, it's worth briefly discussing how health impacts are generally estimated from air pollution. This involves using a concentration response function or a CR function, typically like the equation shown on this slide, which calculates a change in the health outcome in the population of interest based on the change in pollutant concentration they are being exposed to. The factors in the CR function are described more in this table here. One factor is the baseline incidence rate of the health endpoint of interest. For instance, if we are interested in mortality, an example for the baseline incidence rate here would be 5 deaths per 1,000 people occurring per year, or 0.005. For the population value, this would be specific to the age group in consideration for the health endpoint, as well as specific to the geographic area of interest. Continuing with the theme of looking at mortality, an example here could be looking at 25 million 30 to 99-year-olds in the entire state of California. For the beta value, this is a little more complicated, but this is the effect estimate, which relates the health impact to a unit of pollution. Beta values are derived from epidemiological studies, specifically by taking the natural log of the hazard ratio, divided by a unit of the pollutant of interest, like PM 2.5. For example, a beta value for mortality could be 0.0058, which would be derived from an epidemiological study demonstrating a hazard ratio of 1.06 for the association between PM 2.5 and all-cause mortality per 10 micrograms per cubic meter increase of PM 2.5. And the last factor here is the change in pollutant concentration. For example, one may be interested in looking at a 1 microgram per cubic meter increase in PM 2.5. In our theoretical example here then, with all these values plugged in to the CR function above like so, we would calculate about 720 deaths among the adult population in the state of California, occurring due to this increase in PM 2.5 concentration. Now, with the basics about air pollution and health calculations out of the way, we can discuss specifically the health endpoints. As I indicated earlier, CARB plans to quantify several additional health endpoints for PM 2.5. And this is based on peer-reviewed health research using the analysis approach documented in US EPA's technical support document from this year. A portion of the cover page of this technical support document is what is shown on the right side, with the subtitle of Estimating PM 2.5 and Ozone Attributable Health Benefits. This document describes the studies that were selected to be used in the quantification of PM 2.5 health impacts, with the data from those studies now being included in US EPA's BenMap software, which stands for the Environmental Benefits Mapping and Analysis Program. Revisiting the list of endpoints that we presented earlier, in the near term, CARB will be updating our hospitalization and emergency department visit endpoints, which are in purple. For hospital admissions for cardiovascular outcomes, as well as for respiratory outcomes, CARB staff are planning on updating the underlying study for these two. And for emergency department visits, CARB is planning on updating this to be calculated for all respiratory emergency department visits, as opposed to just asthma. In addition, CARB also proposes to add 8 new additional endpoints in the near term, which are listed in blue in the table. These include ED visits, other illnesses, as well as work loss days. All 8 of these are included under the broad categories of health endpoints that the US EPA has determined to have a causal or likely causal relationship with particulate matter, as described in their 2019 Integrated Science Assessment. It is worth mentioning that mortality is not on this current table, but the US EPA has updated their mortality function, which we are looking into. In the meantime, CARB will continue to calculate cardiopulmonary mortality for our regulatory analyses, as we have done for the past several years. All of these endpoints together affect many Californians on an annual basis. This table here shows the estimated number that are due to PM 2.5 exposure in the state. This includes hundreds of hospitalizations for cardiovascular and respiratory diseases, as well as thousands of emergency department visits. There are also hundreds of acute myocardial infarctions and lung cancer diagnoses estimated here. If we look at asthma, thousands of new asthma onset and millions of cases of asthma symptoms are estimated to be due to PM 2.5 pollution each year. And work loss days are also substantial, with about 1 million attributed to PM 2.5 exposure. And lastly, hospitalizations for people with Alzheimer's disease and Parkinson's disease also affect many seniors every year. In quantifying the health effects from air pollution, the US EPA has established a set of robust criteria for selecting specific studies and risk estimates from those studies to be used in quantification of the health endpoints. We have summarized most of these criteria in this table, which the US EPA had considered collectively when evaluating studies. They include study period, exposure estimate, study type, population attributes, study location, health endpoints, study size, pollutant concentrations, hazard or risk estimate, and lag period. Each criterion has its own list of preferred study attributes, and I will highlight some of these. For the study period, a longer period of time and more recent studies are preferred. For study type, which is the third row in this table, if long-term epidemiological studies are performed, cohort studies are preferred over case control studies. Going further down the list, for study location, all the studies selected were either from the US or Canada. For the next one, which is the health endpoints criterion, broad health endpoints are preferred over more specific ones. And the one after that is the study size, where relatively large sample sizes are preferred. More details about these criteria are provided in the US EPA's technical support document referenced earlier. As we have presented, in the near term, CARB is looking to update or add 11 health endpoints, 3 of which would be updated and 8 of which would be new. Each of these health endpoints had 1 or more studies identified as being robust to be used for health analysis quantification. Thus, all of the studies that I will briefly mention in the next several slides for each of these 11 health endpoints had met the collective standard that US EPA had set using that list of criteria. This includes the studies being located in the US or in Canada. This describes all of the selected studies, with several of them having included multiple cities in their study design. Some of these studies also had a large cohort size, long study periods, and had evaluated more recent periods compared to other studies available. Thus, the studies on the next slides were determined by the US EPA to be the best ones to evaluate their respective health endpoints. So now I will go over each of the 11 health endpoints and their accompanying study or studies being used for quantification. First, I will discuss the endpoint of hospitalizations for non-fatal acute myocardial infarctions. An acute myocardial infarction is also called a heart attack, and this endpoint does not include deaths. For this endpoint, US EPA identified several studies that met the robust criteria for quantification, and their titles, authors, journals, and year published are shown on the left side. Therefore, the data from these 4 studies will be used together in CARB's approach to estimate hospitalizations for non-fatal acute myocardial infarctions. The next slide here discusses 2 health endpoints, one being hospital admissions for cardiovascular disease, and the other being hospital admissions for respiratory disease. This study, published in the journal Epidemiology in 2015, was identified as a robust study for quantifying these 2 endpoints. Examples of cardiovascular and respiratory diseases included here are heart failure, asthma exacerbation, chronic obstructive pulmonary disease, or COPD, and others. This slide also discusses 2 health endpoints, emergency department visits for either cardiovascular disease or respiratory disease. These 2 endpoints each use a different study, both published within the last 5 years. Cardiovascular ED visits refer to those for ischemic heart disease, heart failure, and others, while respiratory ED visits refer to those for asthma exacerbation, COPD, respiratory infections, and others. This slide discusses 2 asthma endpoints. Asthma is a disease that's characterized by inflammation of the airways. The first endpoint here is asthma onset, which refers to new diagnosis of asthma. The second endpoint here is asthma symptoms and exacerbation, which refers to the worsening of asthma as measured by the use of albuterol medication. Both of the studies shown here for the quantification of these asthma endpoints were published in 2016. The next endpoint that CARB is looking to add is lung cancer incidence. This refers to diagnosis of lung cancer and does not include deaths. The quantification for this endpoint considers the lag period between exposure and the onset of the cancer. The study here being used to quantify lung cancer incidence was published in the journal Environmental Health Perspectives in 2017. Work loss days is another new endpoint for CARB to include. This refers to the time unable to work due to health conditions. And work loss days are quantified in correlation to elevated air pollution exposures. The study here was published in the Journal of Environmental Economics and Management in 1987. This is quite an old study, but it currently remains the best study at quantifying this endpoint. However, we would like to note that CARB does have a research contract that will complete next year looking at work loss days, which we hope we will be able to use to further update this endpoint. And lastly, we have here hospitalizations for Alzheimer's disease and Parkinson's disease. This study, published in the Journal of Environmental Health Perspectives in 2016, was identified by the US EPA for quantification of both of these endpoints. They both are neurodegenerative diseases, with Alzheimer's disease being a form of dementia and Parkinson's disease being a serious movement disorder. And that concludes the list of health endpoints that CARB is looking to incorporate and update in the near term for a health analysis. This table here summarizes the studies for each of those endpoints, including the age ranges, location, and the effect estimates from those studies. As part of updating the health endpoints, we are also going to be updating the valuation as well, and this will follow this model. First, of course, we will quantify the public health benefits in terms of the quantified reductions in negative health outcomes as a result of a regulation, plan, or project. And then we will perform valuation using standardized methods and data, including from the BenMap tool, and also pulling data from various studies when applicable. This will allow us to estimate the valuation of the health benefits in terms of reduced medical costs, fewer lost wages, and willingness to pay to reduce the risk of mortality, also known as the value of a statistical life, or VSL. And now we will conclude with the next steps following today's workshop. In the near term, CARB will take public comment on these additional health endpoints. And next year, we will release briefing memos for the endpoints, which will include the following information: description of the supporting research, the effect estimate or CR function to calculate the endpoints, general responses to questions raised in today's public workshop, the valuation methodology, and the approximate timeline for incorporating the endpoints in our regulatory analyses. As part of our near-term work, we have also contracted with several science advisors, some of whom are in attendance today. They have been providing us with input as we broaden our health analysis and expand the health endpoints, and we will continue to consult with them as we move forward. For the ongoing and longer-term work, we are continuing to develop California-specific health endpoint data through our research contracts. For example, for neurological and birth outcomes, asthma, and work loss days. We list several of the relevant research contracts on the next slide. We are also exploring how to incorporate race ethnicity data into our health analyses, and we are looking to update our health analysis tools. This slide here contains the relevant research contracts that are ongoing, as well as those that were recently approved. Some of our ongoing research contracts include development of a natural working lands health assessment tool, updating the quantification of PM 2.5 effects on lost work days, and researching non-exhaust break and tire wear health impacts. At the bottom here, our contracts that were recently approved and that will begin soon include tracking health metrics in AB 617 communities and an expanding health analysis contract looking at criteria air pollutant and air toxic effects on brain health and birth outcomes. Further information on the ongoing contracts can be found on CARB's online research page, while information on the recently approved contracts will be added there soon. And last but not least, our expanded health analysis project, including this work to update the health endpoints, is very much a team effort. Several individuals from our management and staff are involved, including Feng Chao Su and Zoe Zhang, who both serve with me as the sub-leads on the overall project, with Feng Chao especially involved on the health endpoint side, including our branch chief, Bonnie Holmes-Jen, and our division chief, Elizabeth Shealy, who you heard from at the opening of this workshop. Many of the people on the team are on hand today to answer any questions you may have. And with that, that ends the presentation. So we will now open the floor up to discussion. If you have a question, you can type it into the Q&A, or if you would like to speak, you may raise your hand to be added to the speaking queue, and we will call on you and unmute you when it is your turn. In order to raise your hand, you will click on the raise hand button below. If you are on the phone, you can dial *9. And with that, I will turn it over to Hei-Yun to moderate our discussion.
Thank you, May. Now, we'd like to go to the discussion or Q&A session. And I think we'll go to the raising hands first, and then later we'll go to look into the question type into the Q&A box. So now I can see Kevin Hamilton, and Victor, would you unmute Kevin to speak? Kevin?
Hi, good afternoon. I'm assuming you can hear me.
Yes.
And good to see so many of you, Bonnie, Barbara, others who I have known for a long time. It's great to see this and see CARB moving in this direction. I'm really excited about this. So I had a couple of questions. One comment just regarding the ER visits for asthma. So I would ask you to take special care there, especially around the Medicaid data, Medi-Cal data, that the plans in California have been actively pushing hard to make sure their patients don't go to the ER, but instead go to an urgent care, and that codes differently. A lot of researchers haven't kept up with that or don't even know that it's happening. So it can disguise, you know, the number of those acute emergent visits. So they're even providing incentives for patients to do that. And they've opened whole sets of new urgent care facilities just to handle these kinds of conditions, not just asthma. There's a couple of others as well. So that would be one thing. And then that's just the comment. The question I have is, we talked a lot about air pollution and more specifically about PM 2.5, which is great. However, I didn't hear any mention of ozone or air toxics. So can you first let me know what we're doing, you know, how that's included in this work, those two?
Okay, great. Thank you for your questions. Yes, the urgent care, there was good comment. Actually, there's another comment from the chat Q&A session, Q&A chat, and also, yes, current studies, mostly they don't include urgent care visit, mostly ER visit or hospitalization. But I think in the future, going forward, a lot of researchers, if they are aware of this, changing code issues, and they will maybe hopefully look into this. So that's a really great comment. So for your question, ozone, yes, we will be really interested in looking at ozone health effect as well. But for the moment, I'd like to focus on PM first, and then primary PM and secondary PM as well. And then ozone will be closely studying and exploring more options in the near future. But that's in our view. So we'll be working on it. Air toxics. Yes, that has been really growing concern, and a lot of people, especially community members, are showing a lot of interest in this topic. But so far in the EP studies, there are not many studies publishing specifically for air toxics per se, because as you know, air toxic is really localized pollution and hard to measure because of the lack of the exposure data. It's hard to link that to the population study base. But as an agency, we are really looking forward to working in this topic along with the other state agencies, and we'll be pursuing more contract looking into air toxics. For example, our current contract with the Dr. Jason Su from UC Berkeley, he's looking at some of the air toxic in Southern California port and rail yard. So that can be another good example that can show some information for us to use going forward. So that's my.
Can I just add real quick?
Go ahead,
Yeah,
Bonnie.
thanks, Heyoon. And I just wanted to elaborate a little and add that, yeah, we are very interested in air toxics, as Heyoon mentioned. We have an ongoing contract to help us better learn how to quantify cancer and non-cancer effects from air toxics. Research contracts are 2 years, and so we don't have immediate data, but we have that contract begun. We also are incorporating air toxics into our research contracts as we move forward when we can. And so, for example, Heyoon mentioned that this Southern California freight contract, which is really important, which is going to get us good information about respiratory symptoms and ER visits in communities near freight centers in the Southern California region. And that also does include a number of air toxics. So the health effect estimate will be calculated both for criteria pollutants and for a set of, I think it's 6 or 8, I have to look at the exact number, air toxics. And the contractors are going to be also looking to see where they can understand the additive effects between the criteria pollutants and the toxics. So we're trying to add this, we're trying to get more of this information as we go forward in our health contracts. And we do foresee in the future adding some kind of quantification of toxics in the future, but we don't have that capability right now.
Yeah,
beyond
Barbara.
the health risk assessment.
Right. This is Barbara Weller. I just wanted to add with the Dr. Su project that he's going to be looking at disadvantaged communities versus non-disadvantaged communities as well. So trying to see that the individuals in the disadvantaged communities, if they have a greater effect, which we really anticipate they will, from these air toxics versus the non-disadvantaged communities. So just wanted to add that.
Thank you, Bonnie. Thank you, Barbara. So now I can go to the next question, if everyone's okay. Umobola Mudasiru. Victor, can you unmute?
Hi, this is Will Barrett with the American Lung Association. Thank you very much for the presentation today. I think you may have called someone else, but I got the cue to unmute myself, so I jumped in. So I'll just go ahead and just say, very much I feel like this is a helpful discussion to really see it all laid out in one place. Especially, I think it's important to see the scientific and research grounding in what you're trying to move forward. I know in that April 2020 discussion before the board, it was really a robust discussion. And I think, really what we take away from it, it's clear that, the current analyses don't paint the full picture of the harms of pollution on Californians or the true benefits of the cleanup. We see this happen in every regulatory process where, we know that the full suite of benefits is not evaluated, it's not analyzed, certainly not provided in monetary terms. And I think that this is a helpful step forward in really explaining the kind of lived experience of so many communities. Really, I think the expanded metrics are certainly more reflective of the stories that we hear from affected communities throughout the state. And, just really want to say, at the outset, thank you for the work and for continuing to put, the work in to kind of help tell that story of why all of this work is so important to our lungs and our hearts and our bodies. So with that, I want to just ask one quick question kind of on the logistics side. And also appreciate that the follow-up going on related to Kevin's question on air toxics. So my question is really, following the public comment you get, the memos that go forward next year, when would you anticipate regulations moving forward with this expanded health analysis to kind of roll out? Thank you.
Thank you, Will. So after this workshop is done, as May said, we'll be working on some external health memo, which includes our previous methodology as well as our current proposed methodology. And then obviously it has to go through some internal or external review process. And so we hope to incorporate this added health endpoints as soon as possible, and maybe thinking sometime next year, early next year or so. But that's my own guess. Bonnie, you'd like to add something about the timeline?
I think that you summarized it well. I think I would just say as soon as possible. As soon as possible. We need to make sure that we carefully review and respond, at least in a general way, to all the input that we get. But then, we hope to get this memo out to nail down the plans and the studies we'll be using as soon as possible. So definitely in the next year.
Thank you, Bonnie. Thank you, Will, again. And so now next hand is Miss Margaret Gordon.
It's always good to have updated health information, but how the information is being presented, how it's being adjusted for each audience that needs to have this information, and that didn't happen here. And second of all, that word disadvantage, we're not disadvantaged communities. We are impacted and vulnerable communities because of poor planning or no planning to let industry come into our neighborhoods, our communities, our towns based on somebody needs to be making money. So I myself, I resent the use of words of disadvantage. We only came disadvantaged because of lack of regulation to be in this spot and be in this time and place right now. So I would really like to stop using that word disadvantage. We are impacted and vulnerable based on poor planning, poor redlining, letting air, water, and soil be optional at not the same level as other communities don't have the same impacts and vulnerabilities. And lastly, where is the word definition for this process? You put all these slides up there, but you didn't have, like endpoint. You think everybody used the language of endpoint every day? So I think that this, I really think it's inappropriate for you guys to be continuously doing these type of workshops and don't cater to the needs of the audience, so they can follow along and understand what you're doing. It's not dumbing it down, but you need to be more including of how you're presenting this. Thank you.
Thank you, Ms. Margaret. Yes, thank you for your comments and suggestions for our use of disadvantaged communities. Thank you for the comments. And for the second comments,
I think Elizabeth might want to respond, or I have a couple comments.
Thanks, and thanks, Ms. Margaret. I appreciate those comments and the terminology. And this is our first sort of general workshop, and if there are ways to have more community oriented, we're happy to explore that as well. We have tried to define some of those up front, including definitely understand that endpoints is not a term people commonly use, and so we did try to define that, but understand we there may be some other terms that we could also define better. So this is the first workshop. This is the first time we're presenting this information, and there may be some follow-on or more specific follow-on with different groups as well. And Bonnie, if there's anything you wanted to add.
Yeah, I just wanted to say that, I'm just really happy you're here, Ms. Margaret, and we would be happy to meet with you and any groups and talk more in more depth about this information and explain any of the terms and get more feedback on how presentations can be more community friendly. So we'd just be happy to meet with you and talk about this more. And I just want to say, in terms of, we actually try not to use the term disadvantage. We're kind of hamstrung a little bit by the fact that when we talk about Count ViroScreen, there's some kind of terminology that's been used for a long time and used in legislation around disadvantaged communities. And so sometimes we use it because it has been, built into some of the some of the analyses that have been done on Count ViroScreen. But we're all looking at terms and how we can use better terms, including impacted communities and under-resourced communities and priority communities, because those are more accurate reflections of the communities of concern that you're talking about.
Thank you, Bonnie and Elizabeth. And are there any more hands up? William Barrett, this is from previous question, I assume, or do you have more questions or comments? Okay, thank you. So if there are more hands up, then I can go over to our Q&A.
Hey, Yun, there was one more hand raised, but I believe they lowered their hand before Victor got to enable their audio. So if anyone still want to raise their hand.
Thank you for reminding me.
I believe not.
Now, as of now, at the moment, I don't see any hands raised. So maybe you can go to the Q&A and then come back if there are raised hands. Okay. So some of the questions STEP experts already responded through the chat, but I will go through some of questions. Linda Rudolph, would you like to speak your questions? Because I know you mentioned a couple of questions in the Q&A chat. Linda Rudolph. Okay.
I can read off her question, at least one of them. Can you help us better understand whether CARB health analyses look only at the anticipated impacts of any particular regulation on, for example, PM exposures, or whether the analysis looks at cumulative exposures? And how will PM health analyses incorporate likely higher exposures to PM from wildfires? So I would just say, for the first part of the question, our analyses do at this point look at the anticipated impacts of a regulation on a specific pollutant, in this case PM 2.5. But we're, as mentioned a little bit earlier, we're actively gathering information so that we can better characterize additive exposures of pollutants. Probably at first that would be more in a qualitative discussion. And then, at some point, maybe we would get to the point where it could be quantified. But at this point, we're looking into how we can better express those additive effects. And then I think I'll ask Barbara, if Barbara could talk a little bit about our research on our natural working lands tool and how we're looking at better understanding the health impacts from exposures to wildfire smoke.
Okay, yeah, we have a number of ongoing studies looking at wildfire. We have a health study that is not quite begun yet, that is going to be looking at what we call the new normal, which is the smoke wave effects, looking at wildfire days to weeks. And we're going to be looking at that throughout California, and that does have a pretty good outreach component to it as well. But we also have a natural working lands tool that we're developing to try to see what the impact of mitigations are on our wildfire production. So basically looking at, the effects of wildfire and the effects of, different methodologies to reduce the risk of wildfire in California. And that is our natural working lands tool. So there are a lot of studies in the research division and throughout CARB looking at a lot of different impacts of wildfire, the emissions, how the emissions differ in different fires, as well as the health impacts. It's a huge area of research, and certainly not just an area for CARB, but a area throughout California that people are really looking at. So those studies are ongoing, and the results are going to be coming out, some of them sooner and some of them a little bit later. Sorry about the dog. Hopefully that helps a bit.
Thank you. So then I'll go to the next question by Elizabeth Kamrai. How are the health endpoints used by CARB? Does expanding the health endpoints on all pollutant broaden CARB's ability to enforce regulation and reduce air pollution? So far, we've been only evaluating 4 health endpoints for all our regulations, which includes cardiopulmonary mortality, respiratory hospitalization, and cardiovascular diseases hospitalizations, or ER visits for asthma. By including more endpoints, we are hoping to show more comprehensive health impacts for our CARB's regulation. So hopefully they can convey more in-depth stories, how our regulation work, and also how much benefit we can provide by implementing some regulation from the agency. So that's our intention. So your question, our answer is yes, that's our intention. And another anonymous attendee asked, is there a written proposal to respond to or just this presentation? What is the timeline for your public comments? That's a great comment. We will provide some information later on at the end of our presentation workshop. You will have opportunity to submit some comments through email by December 20th. So you will have opportunity to provide further comments. Yes, Alisa, yes, for your question, do you have any hint of the approximate timeline for incorporating the endpoints in regulatory analysis? Would it be in year 2020 or more time is likely needed? Yes, as we already talked, we hope to get this used by next year for sure, and as soon as possible. So sometime spring or summer time frame is we are targeting now. Thank you for your question. And Ms. Margaret, after all these years, by now, our CARB staff should know how to develop presentation and workshops as needed for per community, needed to have clarification what being said. I assume we already discussed this one. Ms. Margaret, if you have further questions or comments, you can speak, but I will go to the next one. Kevin, do you have further questions?
I think Kevin wrote a question here, but maybe you can make sure Kevin's unmuted so that he can provide, maybe it sounds like he got cut off. So maybe you could unmute him so we make sure we get everything he wanted to say.
Yes, please, Kevin, would you speak? Because I didn't realize we cut him off. Kevin, are you there?
I don't think they are in the list of attendees right now.
Okay.
We do have a raised hand from David Evans.
Okay, would you please unmute? David, do you?
Yeah, hi there. Can you hear me?
Yes.
Hey, so I'm curious if CARB has any thoughts about the PM and ozone TSD that EPA published. At the very front end of it, it says, it describes really how economists think about people's preferences for avoided health impacts. And one of the things it talks about is that sometimes causality is uncertain, right? And the agency, when the EPA quantifies health benefits from PM and ozone, what it does is it looks to what is a legal evaluation. It's done by scientists, but fundamentally it's in legal support of the setting of the NACs of what is causal and likely causal. And that isn't quite the way an economist necessarily would think about when people would have preferences for something, because it wouldn't necessarily have to be established at that level of evidence. Is that something that CARB has put any thought into in terms of thinking about, going beyond this work and potentially expanding a better identification of what people actually have preferences over for its benefits analysis?
Yeah, go ahead.
I was just going to say, appreciate the comment, and we are looking at, as we talked about at the beginning and throughout, expanding the health analysis in various different ways, both quantitatively and qualitatively. And during the comment period for either this workshop or the written memo, please provide any thoughts you have. And any references as well. We obviously know the TSA, but if there's anything else to add, please provide that in your comments. Bonnie, if there's something you would like to add.
Well, I just want to say, yeah, that that's something we want to look at going forward, and we've have other folks that have made those comments, and so we really would appreciate you providing additional information. Yes, we did see that, and I think that it kind of goes toward how we calculate the willingness to pay to avoid illness or avoid death, and I think those are important perspectives that we want to look at. I don't know if the folks on our economics team want to make any comments on that. I might just provide a moment in case Tony or someone wanted to make a comment.
Yeah, I think you covered it well, Bonnie. Yeah, right now we're focusing on EPA's method, where we're looking at the 3 categories of causality, and then we'll estimate benefits monetarily based on that. But yeah, if you have information that you'd like to submit in support of kind of a different approach in terms of preferences, be interested to see that.
Thank you. And there was another comment. Is there a list of particulate matter emitters by volume or region available to the public? If so, where can we find that? We can provide some emission inventory data or activity. If that works, then we can send you the separate link to the Q&A chat.
Yeah. I think that information is generally available in the annual, I think it's called the Air Quality Almanac that ARB produces, but we can find the link to that. We'll make sure that we get back with that link.
And
I did want to note, because you mentioned Kevin Hamilton. I'm not sure that if he's still on or not, but he did have a question in addition to his comment when he was asking about contracts to study possible epigenetic impacts of BTEX exposure for those living near active oil and gas activities. And we don't have any plans at this moment, but we would invite people to submit ideas for research concepts in our research planning process. And we did just also complete a very important set of research contracts that were focused on studying health impacts near oil and gas facilities. And we have a final report available on that research that we could get to anyone who's interested. But I wanted to note and respond to that comment. Go ahead, Heyan, sorry to interrupt.
Okay, no problem. And then Catalina Gonzalez asked, can you please clarify what new updates and additions to health endpoints CARB will include as part of air quality and public health analysis that is required under 2022 scoping plan updates? Oh, that's a great question. So the scoping plan has another health analysis section, and they will be using the EPA BANMAP software and work. So having that said, they will be adding additional endpoints such as we mentioned earlier, some neurodegenerative work endpoints, or just more broader lung cancer as well. I think that's what we are aware of.
I think the intention is to incorporate these new health
Everything.
endpoints that we're bringing forward today, assuming that we can get the process that we described, kind of get through all that in parallel with the scoping plan process. But the intention would be to incorporate those new endpoints into the scoping plan analysis.
Thank you.
The quantitative analysis.
And does this Daniel Chandler, does this project have any relationship to the CalGEM use of public health data for its current rulemaking? Bonnie or Elizabeth, do you have any comments on that?
I'm sorry, can you, I didn't quite hear the question, and I'm trying to find it written down. Maybe, would you mind repeating it?
Sure. Does this project have any relationship to the CalGEM use of public health data for its current rulemaking?
Yeah.
Not
I
directly.
I don't think there's any direct connection at this point. I mean, we're certainly communicating and sharing information about the different health information that we're collecting, but there's not a direct connection between how we're doing our analysis and how they might be incorporating health into their analysis. And Elizabeth is nodding, so I guess you don't have anything else to add. Don't forget, there's a few other questions up here. I just want to make sure don't get skipped over. I think Irva Hertz.
Yes, I kind of communicating the staff.
I'm sorry.
I'm communicating with the staff. Who's
Oh, okay. I'm sorry. Yes. So make sure we don't forget some of these other questions that came up. Okay. So we're getting the answer to that one. I think Irva had to leave, but we'll still get the answer for her. Okay. And we thank Wendy for her additional comment that Miss Margaret's point needs to be taken into account in future presentations. So we hear your comment. We need to consider all the audiences. So thank you for that comment. Appreciate that. It seems like Linda might have more questions. She said her audio is not working, but I didn't see another question.
But she had a previous question. We already answered the recent question, but then there's another question from her earlier about why don't we include reproductive endpoints for our endpoint? And so
I think I typed an answer. I think I did type an answer to say that that's something that we plan to include in the future, and that we're collecting information about that, and specifically have a research contract that was listed on that slide. And we'd be happy to share more information about that contract, which should be starting early next year.
Yes.
Very exciting. And then I think, let's see.
And then Sharifa Taylor, is race ethnicity exclusively going to be investigated, or will other common barriers like language, education level, and income being assessed in conjunction with race? Thank you for the comments. At this point, we'll be really closely looking at the race ethnicity for the moment, because that's the place where EPA has done a lot of thorough review. So we'll be hoping to using it in our future work. But the language and education level income, at this point, we are not looking into it yet.
I mean, I would just add, I would really, this is a comment I think is really important, and we'd like to get additional information and perspectives on how we can best incorporate this into our health analysis. So thank you, Sharifa, for raising this. Part of the purpose of this workshop is to raise, these initial health endpoints that we're bringing forward, that there's additional ones on the list, and that we're seeking comment on both these endpoints and other thoughts for how we can best expand our health analysis as we move forward, including how we can better incorporate race, ethnicity, and other community factors. So we're open to comment and input on those questions. As Heyun said, we don't have a methodology at this point in terms of in terms of some of these factors that are mentioned, language, education, and income. At this point, those are being more addressed qualitatively and more narrative discussion of community impacts and just the community conditions that we know are adding to vulnerabilities. But we're interested in your input as to how we can best take them into account, and comments on whether it can be these factors can be used both qualitatively and quantitatively.
And since we're on that question, I see that Sharifa has her hand up. If we could unmute her.
Great, thank you. Sharifa?
Hi, can you all hear me?
Yes.
Yes, this is Sharifa. I'm part of the EJAC, and I'm part of the Public Health Working Group. The reason I asked this question was not to say like that the other things I asked about, like language, education level, income, should be considered as well, but it's more about the intersection of those things. And that's why I was asking that, because it creates an even higher burden for folks when dealing with these issues. And so if they're not something that immediately is going to be included, like race or ethnicity, what is the plan to start thinking about that or including that type of data as well, in order to get a more accurate depiction of what folks are going through and the type of work that needs to be done. So you can answer the question now, but also we can save this as well for the working group, because it's related to the work we're doing on the scoping plan. But I think it's just something that, as you all are updating your tools and the way that you do things at CARB, it's something that should be considered, because it's just it's being doing due diligence. Like I think it was great what you said, I believe, Bonnie, about like you're taking some of these things into account qualitatively, but I think also being able to like get some of that data quantitatively, like whether it's from the census or the different health surveys that are out there. I think stuff like that is fairly common to do. And so I just wanted to pose it as a question, but also bring it to your awareness if you hadn't considered it. So that's it.
That's very helpful explanation. Thank you, Sharifa. And I think we should continue the discussions on these topics as in the working group and other venues. We're very interested. Phil Martin had a couple questions.
Yeah, May is answering for the first question.
Yeah.
Do chat.
Yeah, I was wondering if CARB will be using BEMAP directly or developing new tools. I know May maybe getting back to you, and I would just say, and may have some things to add, that one tool that we're using is our kind of the tool that we use for our routine regulatory analysis, which is called the incidence per ton method. So that's one tool we're using. We're also looking at how we can update that tool, and so I would say that we're using a mix of our current tools and looking at how we can develop new tools. In some cases, we would be using BenMap directly. That would be in cases where we have modeled concentration data, which is not for our routine regulatory analyses.
Thank you.
And we would love, yeah, we would, again, this is another area we appreciate your input input, Phil. We're looking forward to working with you, Phil, on some of the work that you're doing. I know we had some back and forth about the important PM risk work that you're doing at the district, and we hope to be more engaged in working with you on that and have some further discussions set up so we can learn more. I know you've got I think a Bay Area Air Quality Management District Advisory Committee coming up, and we'll make sure that we are attending that to learn more about it. So, but yeah, we would definitely like to have more discussions with you about how we're using our tools and get your input. And in terms of you asked about the letter, I think that the letter, I believe, is public. We will double check.
Yes, I think so. So we can get back to you, Phil. Yes,
yeah.
We just submitted 2 weeks ago, so it'll be in our public docket from EPA.
We'll just make sure. I believe that it's on the public docket, as Elizabeth mentioned, and so I think that we should be able to share that. Okay.
And then the Urba's question about what is the rationale for only including hospitalization, which may be a small fraction of the cost associated persons who develop Alzheimer's and progress to severe stages, open decades before physical health decline. So we are depending on EPA ISA document as well as TSB, and the many epidemiological studies are not available, I guess, unless this is hospitalization data. And also for the economic valuation purpose, I guess there's some lack of information related to the severity of the Alzheimer's and Parkinson's. But fortunately, we have our current ongoing contract with the Biaras Ritz from UCLA and Jason Su, and they are going to look into the Parkinson's and Alzheimer's disease endpoints, specifically from California. So hopefully we can fill some more gaps in there. But this is a good point. We can look into more in detail about these 2 endpoints for our analysis. And there was a comment about oil and gas report. And this will be publicly available beginning of January. Is it correct, Barbara? Or
yes. And also there will be a seminar that we're scheduling for that, a final seminar for that contract. So that would be very informative for people on the oil and gas effects.
Barbara, could you just give a very high-level summary of what's in that contract? I know there's a lot of pieces to it.
There are a lot of pieces to it. Yeah. This is a contract that we had with Rachel Murillo-Frosch and colleagues. And what they did was they looked at the production of oil and gas and the distance and looked at birth outcomes. And what they found was that there was some effects, particularly in the let me get this right, hopefully urban communities instead of rural communities. I think I've got that right. Where they looked at the effects of low birth weight. And they also looked at water and water contamination. So there are a number of different components of that, and quite a few papers that came out of this study. One of the things that I think is going to be helpful is the seminar that's going to try to kind of pull this all together and talk about the oil and gas effects as a whole.
Thank you, Barbara. So stay tuned for the seminar. And otherwise, I think we cover all the questions through Q&A chat. I'm going back to our raising hands participants. David Evans, I think this is from your previous question, I assume, or do you have additional questions or comments? I'm just checking in to see. I assume not. And any further questions through Q&A chat from the participants?
This is Bonnie. I was just thinking that I know one person had asked about how we use the information, and I think you answered that very well, Heyun, but I thought it might be helpful just to show, I think we have a slide that just shows how the calculations that were included in a past regulation, just as a concrete example of how we use this information. So I don't know if May has that available for
Slide
folks.
number.
So you wanted to show the example regulation from US EPA incorporating the new endpoints?
Well, do we have one of ours, or I mean, it could be one from US EPA, that's fine, whatever you have.
Okay.
Yeah.
I do have an example of a previous example from CARB, just incorporating just using the 4 health endpoints.
Yeah, yeah, just kind of show
yeah.
example of what we've done in the past.
Okay.
So just to make it clear for people what this all comes out to. Here's what an example of what has been in a regulatory document in the past. So
I'll just go over it really briefly. So we provide the cumulative health numbers for these 4 endpoints: the cardiopulmonary mortality, hospitalizations for cardiovascular illness, hospitalizations for respiratory, and emergency room visits for asthma. And these are, this was for an example regulation here, cumulative for the years 2022 to 2034. And for some regulations, we also break it down by the air basin as well. And it would be provided like so, in this way.
And then the parentheses.
Yes. So the numbers outside the parentheses, they're the central estimates for each endpoint, and then the numbers in parentheses, they are the 95% confidence intervals.
Thank you, May.
Yeah, thanks. So just we're proposing again to add all the endpoints that we're talking about into this routine regulatory analysis, so that when we analyze a regulation such as was just shown, that was the transport refrigeration unit regulation, we'd be able to quantify the expected benefits in terms of the reductions, the reductions in illnesses and deaths. And now with this additional data, we'll be able to calculate this much broader, more comprehensive understanding of what those benefits would be. And I might add, I know there were questions about additional pollutants, and as we commented, we're very interested in looking at pollutants beyond beyond PM 2.5. But I also wanted to comment that we're still building out the information so that we can provide a more comprehensive look at even at the impact of PM 2.5. And when we're looking at PM 2.5 health impacts, we're looking at the health impacts from the direct emissions, as well as the secondary formation, the formation of PM 2.5 from precursors, or other types of pollutants that combine in the air to form PM. And we still have some work to do to be able to fully calculate and to evaluate the health impact of all those precursors on creating PM and health effects. Where our analyses right now are fairly conservative, really, because they're not taking into account all of the precursor emissions. So we still have some work to do. We're working on right now, trying to fill out both our analysis of the PM 2.5, and then we do hope in the future to be able to incorporate other pollutants. Just kind of elaborating a little bit.
Thank you, Bonnie. So I don't see any more questions either through raising hand session or Q&A chat box. So I guess this will be the last part of our workshop, I guess. So, but yeah, and next slide. Okay, so this will conclude our workshop today. I want to thank everyone for attending today. And if you have more questions and you'd like to provide more comments or questions again after this workshop, please email them to me by December 20th. And my email is on the screen here. And we will review all comments and questions, and we will address them in a future briefing memo next year. Thank you, everyone, and happy early holidays. Thank you, everyone.
Thank you.
Thank you.
Thank you.